Namaskar. Welcome to this 10th podcast, Gyan Pravah, the brainchild of our president, Dr. Sunita Tandulwadkar, madam. I welcome Sunita, ma'am, and I also welcome Ashok Khurana, sir. Welcome, sir. I'm really happy and grateful to have you here. At the outset, I would like to say a few words about our dear president, Dr. Sunita, ma'am. We all know that she is the president of Fogsi this year, and she is the president-elect of ESAR, has been the founder president of Society of Ovarian Rejuvenation, and has had multiple posts in almost all societies that run in obstetrics and gynecology, has a lot of papers, publications, books. She is very beautiful to look at, but believe me, it's also true that she has that beauty inside where, whether by danda or by love, she is able to pull out the best from each one of us. So she motivates us, and I can see why God decided that she should be the president, because she's the true leader. So, ma'am, really welcome and honored to have you here, and we would love to hear a few words from you.
Thank you, Asha. Thank you for your kind introduction. Dr. Ashok Khurana, it is an honor of Foxy to have you on our podcast series. The 10th podcast, believe me, the enthusiasm, the passion, the creativity of all my committee chairperson is so fantastic. Every podcast, I feel that day, oh, this was the best podcast till now. And the same feeling happens for every day. We may get in academic people, we may have national, international academicians, we do have politicians, social worker, philosopher, mental health, so many varieties. So these committee chairperson are using their best of the knowledge, their best of the contact. They are thinking beyond the boundaries and they are trying to give their best. My request to every Foxian and non-Foxian, because on a social media, on a YouTube channel, on a podcast stage, we are releasing these videos. So all of you, 8 o'clock every day, please tune to Gyan Pravah. My committee chairperson, I want every one of you to love them, to support them, to encourage them, because they are the leaders of tomorrow. They will be leading the Foxy. One of them or few of them will be leading the Foxy. I'm very sure about it. And by this podcast, they are coming out with their oratory skill, their leadership quality. And I'm so glad that everyone feels at the end of a podcast that they have achieved something. And that feeling is very important. And their restless nights before the podcast brings best out of them. And I love all of you, darling. Foxy doesn't work only with president. Foxy has pillar of strength, 5 VPs, 30 committee chairperson, and 286 society president secretaries. Apart from the other admin staff of Secretary General, Joint Secretary, Treasurer, Joint Treasurer, and most of all, my beautiful Joint Secretary, Dr. Ashwini Kale. Without her, I don't think I would have enjoyed my podcasts or my Foxy presidency so much. So thank you, all of you, for being here. And I'm sure, you will make us speechless. Absolutely great. Of course, the pattern is I'll be joining from the delegate link, and you and Asha, the A square only, will be in the frame. Thank you. Thank you,
Thank you.
Asha, for thank you having Ashok and Ashok. Always no my presidential conferences happens without you.
True. Thank you
Thank
Thank
very
you
much.
so much, ma'am.
Thank
Thank
you.
you so much. Thank you for all those wishes, and we'll try to do our best. Thank you, ma'am. So now I would like to introduce Dr. Ashok Khurana, sir. Again, a luminary who needs absolutely no introduction, but it's a challenge to me to introduce him well to those who already know him. So, sir is an MBBS from AIMS Delhi, MD in radio diagnosis, also from AIMS Delhi, and has been trained in Herlev Hospital in Denmark in ultrasound. He is the chairman and consultant in reproductive ultrasound in Ultrasound Lab, New Delhi. He has been practicing ultrasound in New Delhi since 1980. He is a professor, School of Health Sciences, Dubrovnik International University, Croatia, professor, Indian Medical Association, 2017 to 20, past president of Society of Fetal Medicine, but he continues to be the patron and the force behind the Society of Fetal Medicine and all the work it is doing till now. He's the former ISWAG ambassador in India, former dean, Indian College of Medical Ultrasound, mentor emeritus Society of Fetal Medicine, director scholar MD Fetal Medicine Program, program director Apex Institute of Fetal and Reproductive Sciences, editor-in-chief Journal of Fetal Medicine, and president-elect 2526 of Indian Federation of Ultrasound in Medicine and Biology, IFUMB, next year. Welcome, sir. I would also like to tell everyone that my introduction to ultrasound was by you demonstrating the NT scan. And it caught my heart, and I ended up doing all the courses I could do in ultrasound. And it's all because of you, the encouragement you have given, and the push you have given whenever there's been a bit of slack. Welcome to this podcast, sir.
Thank you. Thank you so much. And my special thanks to Dr. Sunita Tandulwadkar for this wonderful welcome. I have looked forward to her leadership at Fogsi for many years. I am now a member of Fogsi for the last 41 years. And the last AICOG in Mumbai was my 40th AICOG. So I'm very proud to be a Fogsian. And no wonder a lot of people call me uncle and dada and so on. So it's indeed a pleasure. And I really wish to thank her and to thank Dr. Asha Jain for having me on this program. It's a great new medium. And I'm so glad we are learning that we need to communicate with ourselves. We need to communicate between us and our colleagues. And more importantly, we need to communicate with the world and make sure that every new idea is shared with the world while it is raw, while it is evolving, and of course, after it has continuously evolved. So thank you indeed for having me here. Thank you indeed. And thank you, Sunita, once again.
And
Thank you, sir.
enjoy your dialogues, and I'll be listening to you. Thank you.
Thank you.
Thank you. So, sir, our topic is AI in imaging.
Yes.
What are the breakthroughs and what are the boundaries where we should not be trusting it over much? But before we go into the topic proper, I would like to ask you how you actually landed up with fetal medicine and ultrasound in the first place. How did you land up here? Do you come from a family of doctors, or what actually motivated you to take up medicine and this specific branch?
Not a very long story, but for those who are interested, I was not particularly keen on being a doctor, but I belong to a generation where we always did what our parents asked us to do. So if my father wanted me to be a doctor, we took the exam and I became a doctor. When I became a doctor, I realized maybe I'm not in the right field and I should be doing something else. And then said, no, you're an Amsonian. How can you give up? So I said, let me take a field where there is less patient contact. And I opted for radiology. And before I could even enter radiology, ultrasound made an entrance. And I was fascinated by technology all my life. And I said, okay, let me give it a chance. And my head of the department, Professor Sneh Bhargav, at that time said, there is this new technique, and I believe it's going to be better than CT, cheaper than CT, and you better do something. I said, but ma'am, I come from a family that has limited resources. I have to go into private practice. I have loans to look after. She says, you finish this and then go. I said, yes, but will you let me go the day I finish my post-graduation? And she said, yes. I also, at the same time, did a degree in obstetrics and gynecology, which currently is no longer recognized, but that's how I actually got into this. And then while I was being mentored by Dr. Sneh Bhargav, Dr. Kamal Bakshi, at the All India Institute of Medical Sciences, had been encouraging me all along to take a greater interest in obstetrics and gynecology. And it was natural, therefore, that I got stuck at the crossroads. And I said, okay, I will choose both. So I pushed ultrasound, and we pushed ultrasound and obstetrics and gynecology all at the same time, did everything at the same time. And then I realized that, yes, I'm on the right track. And then I realized also that in government at that time, it was very difficult to get equipment released in a general hospital. And I better move into private practice. And that's what I did. And within a few years of private practice, 3 years to be precise, I realized I had to specialize. So I went into ultrasound and obstetrics and gynecology and have remained there ever since.
Okay. That's very interesting. But sir, just for my interest, what is that course in obstetrics and gynecology you did, which is not recognized anymore?
It was called a Dawn DGO.
Oh,
Yes. And all
yes.
of us did a Dawn DGO because they were new evolving fields. And just like
Hmm.
we have in the US currently, you can be part of a gynecology department and part of a radiology department, and you can be in obstetrics and in radiology, and you can be in
Hmm.
genetics and you can be in obstetrics. That does
Hmm.
not exist in our part of the world. And then, so I had to choose one as the mainstream. And I said, I will do my Dawn DGO at the same time. And then, of course, it went out of existence. So of course, on that basis, I did become a Foxian. But, now we have different categorizations. Yes.
Okay, that is really interesting. Now, another question is, sir, that, there are a number of practitioners. There are people who have their own OPDs, they sit, they see patients, they make an amount of money. But you didn't stop there. What actually inspired you to take ultrasound, that you need to do better ultrasound, it has to be taken to the people, some quality has to be pushed in? What actually made you do this?
People get very surprised when they hear this answer from me, but I never could come second in anything. My ego never
A
allowed
class personality.
my ego never allowed me to come second.
Okay.
So, truly speaking, it was to satisfy my ego, but I was able to channelize my ego into progressiveness. Most people think it's a negative quality, but it is also a quality, if harnessed correctly, it pushes you on to make sure that
Okay.
whatever you give yourself, whatever you give your patients, whatever you give your family should be nothing than the best. And that is how I got pushed into all of this. So whether it was pushing equipment, whether it was pushing genetic tests in this country, whether it was pushing education in obstetrics and gynecology, or actually inspiring the younger generation to take up fetal medicine as an option, I said, I have to do that. And hopefully a lot of those bricks have fallen into place and we have a good wall standing now.
So that is true. But what I'm saying is, you can never be second in anything, that is fine. But what made you go into training, getting more people? You are getting competitors for yourself, right?
Yes.
So, what actually made you go out that we need more fetal medicine people, we need more gynec ultrasound people? What was that in your heart that made you, share your skills?
I think it was my cultural background. I'm the son of an army officer, and
Okay.
we are always economically deprived, but nobody notices. And there was a fun life always, and fun was of the essence. It wasn't money. And yet, in the background, we did realize there is human suffering that is not addressed because you meet people from the poorest to the richest, from the most socially deprived to the most advanced. And yet, you meet people from small towns, very small towns, villages, men who've never visited their wives except for 2 months in a year, and so on, because those are our soldiers. And I said, I have to do something for deprived individuals. And the big section that I could do it for was women's health. And I said, let me move towards that. People at that time were going into bone health, cardiac health, gastroenterology, diabetes, and so on. I said, look, why can't we just improve women's health? And that's where the interest came along. I, it used to hurt me intensely to realize that people are dying of anemia and sepsis. And those were the two leaders in my time. And we never had blood, and we never had antibiotics that were available. And I said, let me create a situation where technology pays for the rest of healthcare. And that is what is happening now, that we realize that we've integrated it and it's working. But the background was this, that I saw too many deprived people. I came from, well, I won't say an economically deprived background, but not a rich background. And so I knew people suffering. And that's where I took it up from.
Okay, so the basic thing is what I would like everyone to realize is that true work comes from the heart and not from the head.
True. Completely
So,
true.
so
Yeah.
it was your heart that was triggered, and you have ended up where you are and still going on. So you made Society of Fetal Medicine. Then a lot of education is happening around the whole country and outside it in the name of Society of Fetal Medicine, for fetal medicine, for ultrasound. And ultimately, it is improving the quality of care that women are getting. You're also an advisor to the government. So, how has your interaction been with the government wherever ultrasound for pregnant women is concerned?
It's a long story, some with very sad portions, because when we started ultrasound, we did realize misuse was happening. So we wrote up the first PCP and DT Act. It was put on the back burner, and this happened in the early 80s. And then somebody pulled it out in 1994 or 96, if I remember correctly, and said this will be the new act. And they said, you know, uh, ultrasound is only to be done for women above 35. They cut pasted in a time when there was no cut paste, but the typist did not get it right, and the act went completely wrong. And then I realized that I have to handle this problem from the inside. So since then, every document that I am ever involved with, I read myself. The next thing we did realize was that you cannot do this either by government. You cannot do this by government alone. You cannot do this by private alone. You need a public-private partnership. And so I decided that we will get talent from both sides, that we will get the reach of the government to every single primary health center, and we will get the reach of technology and the people promoting it and the people who need it to be used, because technology is of no use unless someone can use it, and therefore a machine has to be sold. And the only way to make a machine sell is to make people aware. So we took money from manufacturers, we took money from genetics people, we took money from people who had sort of a philanthropy in the pharmaceutical companies without their direct influence. And we put it together to create good work even at the primary health center, finally. And we knew it's not going to be possible separately. Some of us got grants from the Bill and Melinda Gates Foundation, some of us from UNICEF, and most importantly, also from government. So Professor M.K. Bhan at the Translation Health Institute in Delhi, in Faridabad, and he had ministerial status. He inspired me, a pediatrician who said that we don't know how to handle government and we don't know how to handle government money. And each one of us as a physician is responsible for making sure that the money reaches the right person. And we cannot let it go one side or the other because of politics or bureaucracy. It must reach the people of India. And that's when I started going back into primary health centers and realizing what was missing. In fact, Odisha, we did our first program where every single primary health center was promoted to an FRU, a first referral unit, with an ultrasound scanner, a medium level, not a low level, and a blood bank. Because we realized that identifying problems in obstetrics and blood were the two most important things for triaging patients that need further referral or can be handled there and then, and what is the problem. And it worked very successfully. So we trained people by a virtual medium. It was COVID time. We got those machines going, we trained the trainers, and we got the blood banks going all at the same time. And within 2 years, now the results have come out now because the Survey of India works later. We realized that Odisha moved from right at the end of the ladder of maternal mortality way up to 15. just by these two interventions. So it really has been a very
Great.
satisfying journey. And now we're replicating it or trying to replicate it in other states as well.
Okay. So that is quite some work. And all your humility, though you say you're a type A person, but your humility in spite of getting this colossal work done. Hats off to you, sir.
Yes, we had a
So,
wonderful local team. I must acknowledge my people on that team, and we had Dr. Shama Kanungo and
mm.
Dr. Hasmukh Lal who really pushed this activity there, along with the government at that time.
So, sir, when you were being formed as a doctor,
Yes.
and afterwards, after you started private practice, there must have been a few people who inspired you, who actually helped you along your journey. You've named Dr. Bhargav, you've named Dr. Kumud Bakshi. But other than that, others who actually, pushed you into the right direction, because when we are forming, there are always people who are inspiring us, who are helping us go forward. So if you could, speak about a few of them and their contribution to your journey.
So my mother was perhaps the greatest influencer in my life. And she used to say, look, you don't need grand resources to do something good. And, she'd been an army officer's wife. She'd seen partition. She'd seen the aftermath of the Punjab partition into Pakistan and India. She'd looked
Mm.
after a family of 54 people living in 2 rooms for a period of over a month and a half. And so she'd seen a lot of hardships, and she realized that it's having a heart and not the money that matters. And I think that is something I remember all her life as a lesson she taught by living through it. And then beyond her, really speaking, it was just too many people along the way. I think every person I used to meet in those days, I lost my father during my MBBS time, and we had a bit of a hard time economically. So I did not stay in the hostel because it was more expensive. It was cheaper to stay at home. I walked because it was saving me money for the bus, and I didn't cook at home because it was cheaper to eat in the canteen. So the 1 rupee I saved on the bus would save and give me 1 rupee for my lunch, which is all I needed for a bowl of rice. So then, when you've been through these things yourself, you realize that if you reduce your own requirements, you can still live. And yet, when it comes to health, you need more requirements. And so I should work towards that rather than greed. I should go for other people's need and then move on towards that. So this is every single person in my life, every single person I met on a bus, every single person who I met in a third class compartment, every single person on a railway platform, every single person on a farm and so on, where my father used to work. I think they influenced me one by one, millions of Indians.
So, my pranams to that, sir. And now I want to ask you another personal question
Yes.
that I've seen you for, I don't know, maybe 10 years, maybe more. But all the time, what strikes me is that you are striving for quality, more quality, and even more quality in all the scans that you do and all the scans that others are doing. And for that reason, you have started, the trainings and the standardization. If you would like to say something, what is this so much about quality? A scan is a scan, right?
No, a scan is not a scan. A scan today in obstetrics and gynecology is the basis for clinical decision making. If you make a mistake, and this is your major building block, you're letting the patient down. And if you don't have a quality scan, therefore, you're making the wrong clinical decision. That would be a complete disaster, which is why I push quality and quality and quality. The other thing I like to push is time. As physicians, we've learned to give knee-jerk responses. The patient has barely walked in, opened her mouth and started telling her story, and we're ready writing out a prescription, and we often don't do a clinical examination, a physical examination. That's not good practice. We don't listen to her story. That's not good practice. We pretend to be overloaded when actually we're hardly spending any time. I'd rather stretch the end of my day and do good work than rush through and make snap decisions, especially if I haven't spoken to the patient. So we have juniors, the so-called juniors in the medical profession, coming in telling us a story, which is their interpretation of the patient's story, and it's not adequate. I have to interact with the patient and then give an opinion. Otherwise, I may as well do virtual practice and via Zoom rather than via direct contact. So I think that becomes extremely important, that we have that quantity of time to spend with our patients, irrespective of whether we work in government, irrespective of whether the chokidar is standing on my head to shut the clinic in a government organization. I just think we have to fight that system and make sure that either I get more people to work, I get more machines to work on, I get excellent machines to work on, or I just do it myself until I've done my day's work.
Okay. So with that, that is the introduction of our podcast. And now we come to the topic proper, sir.
Yes.
So AI has come up in a big way. Now there is AI in everything.
True.
AI is also coming up in imaging, whether it is MRI or it is CT scan or an ultrasound. So what do you see AI as? Do you see it as a friend or a foe or a threat? Is it going to take away our jobs? And is it going to replace experts? So basically, what are the breakthroughs that we have in imaging is what I would like you to address first. And then we will go to the boundaries.
So there is no doubt that the best facilitation that we have received to date is from artificial intelligence. And we cannot use it for the disappearance of normal human intelligence, which is also happening now, because people don't want to apply their mind and their mind is always elsewhere. And that seems terribly unfair. But what I firmly believe in is that if you learn how to harness the power of AI and you understand where it originates from, and you understand where the technology has come from, and how much is reliable and how much is not, because with any scientific field, there is always garbage and there is gold, and you have to strike which one is which and which one is the best. So there is no question of it ever being a threat, because if you see it, it will always facilitate. And if you're not doing a good job and not doing an honest job, you will going to be lost anyway. So if you were already a lost person, then you'll get more lost, and you deserve that. And if you are a person who's forward-looking, honest to oneself, and goes by your conscience, you will love AI.
Okay, so actually, even the simple chat GPT, it hallucinates a lot. It hallucinates. You give it something, it hallucinates. Now, in imaging, if the AI is hallucinating, how can I, as a clinician, know that it is hallucinating? It is not giving me correct answers. How do I actually judge it?
So the most important thing is to always use any AI that has already been proven elsewhere. So an AI is something that happens. We first get lots and lots of data, big data as we call it. Then we put it through the simple steps of deep learning, and then AI starts thinking for itself, and you get these neural networks. And then we have a logical conclusion to that AI. And then we have validation, which is internal validation of its use, and we have external validation of its use. Once anything has been through external validation, you can be sure that it is reliable. And therefore, it's important when you start any AI to look at the papers that relate to its validation. For instance,
This is most important if you would elaborate on this.
yes. So for instance, the first thing we seem to forget is that there is a difference between true artificial intelligence and automation and assisted decision making. So if I have an app in which I tick off, for instance, an app that is for preterm birth, that is not artificial intelligence currently. It is an app which is available on the internet and can be downloaded on your phone, which says age of the mother, previous miscarriage, length of the cervix, and ethnicity, previous miscarriages, diabetes, etc., hypertension, and so on. You tick that off, it gives you a score, and it tells you what is the risk. That is assistive computing. That is not artificial intelligence. It's the same thing when we are defining, for instance, shoulder dystocia, or the risk for preeclampsia. All of this is something that is only assistive and mathematics-based, computer-based, but is not artificial intelligence. Also, the risk for gestational diabetes, the risk for some of the other things such as prediction of vaginal delivery. Again, this is assistive. It's not true artificial intelligence. Artificial intelligence is that I look at a fetus, which is somewhere between 11 and 14 weeks, and without telling the machine the crown rump length, the machine looks at it. It has been fed with lakhs and lakhs of fetuses at that stage, has learned to recognize something that you and me do not recognize, and then tells me this baby is 12 weeks, 4 days. That is artificial intelligence because it has been trained and then can train itself like the human mind. Now, to get that kind of work is rare, but it is happening. And as long as you and me can differentiate between assistive computing and true artificial intelligence, that is our first step. The second thing is, where do I use artificial intelligence? And then we go through the history of artificial intelligence and see how that works. So in 2022, as recently as that, just after 1 or 2 years after COVID was saying bye-bye, we had the American Journal of Obstetrics and Gynecology, in their section on maternal fetal medicine, told us that artificial intelligence is not ready for prime time, to use the original word. Strangely, the Lancet and the British Medical Journal did not agree at that time and said we should be ready to learn how this works, assess it for ourselves, and translate it into clinical practice. We had companies that caught on to this and realized that they have to pull up their pants, tighten their belt, and make sure they're ready for this battle. And they did so. And I had been already involved pre-COVID with a lot of data, and I realized how it works. In fact, some of it has been translated into a machine even during COVID times. And we have excellent ways of now teaching, where on the basis of the images that we provided, the equipment recognizes that this is the right frame for all my ISWAG 20 planes of the mid-trimester scan, lets me know as a beginner that this is the right plane. It takes measurements as we go along. It's called AI sonobiometry, and gives me teaching as I go along every day that this is what I need to do, and this is the list I have completed, and what more do I need to do. So it's helping education and clinical practice at the same time. And since this has been done, it's been validated, it's been translated into commerce, it's working very well. Then the other simple thing that we started parallel was we realized that we were measuring heart rate in terms of embryonic heart rate and fetal heart rate, but we had to press one key, separate out the M mode, and then never use Doppler in the early pregnancy, and then try and get a heart rate. And yet, when we put AI onto recognizing that pattern, it told me an unbiased embryonic heart rate. So if it was 99, it was 91, 99, and I couldn't say, oh, she's bleeding, let me make it 91 and tell her not to carry on with this pregnancy. So it helped us to tell the truth. Similarly, now we've expanded that in the heart to talk about cardiac arrhythmias and the recognition of arrhythmias. Also, we now have fed computers with so much information of normal hearts that when I'm scanning my heart in the region of the heart, without sometimes getting the right plane and sometimes getting the plane, and baby's moving and I am moving, and I haven't worked hard enough on the image, it recognizes the image and tells me, okay, we've got these 9 planes and these 4 are still to be done. And it applies to the echocardiography planes as well. That is true artificial intelligence. And again, internally validated, externally validated, and ready for clinical use and in use.
One thing I would like to ask here, sir, like you were telling about the preterm labor.
Yes.
You would still need to put the probe correctly on the cervix, right?
Extremely correctly. So
So
your skill
that
has
is
to
what,
be
that
correct.
your skill is not replaceable. You
It's
would
not.
still have to learn to put that probe correctly.
This is
You would,
precisely what I was coming to, you see.
yeah,
So our most common threat in obstetrics is preterm delivery. And preterm birth is what you and me have to look after. Now, we know that in every single case at 20 or 22 weeks of gestation, we should do a transvaginal evaluation of the cervix. I must do it correctly. Without me doing it correctly, I will never get that longitudinal section. I must get an endocervical canal and I will measure it with a straight line. What I can also do at that time with artificial intelligence is without my measurement, because I'm not sure whether my cutoff should be 25, 15, or 10. I can put that into artificial intelligence, and this is already commercially available. And the machine tells me not by elastography, but by artificial intelligence, that my risk in that particular patient for preterm birth is 1 in so many. And then I opt for progesterone or cerclage. Now, this is fantastic. And so, therefore, it will never dispense with your skill in obstetrics. Your skill can be
that's what.
enhanced by AI, but your skill will still have to be at the core of everything.
Because you
Yes,
just now you were saying 20 planes of ISWAG. Now you would
yes,
need to know those planes, right?
yes. And
So basically, that skill can help you. AI can help you,
yes,
but
yes,
it can never replace the skill, and you need to know what is right before you can judge whether AI is doing the right job or not.
yes. After a few years, perhaps the machines would be intelligent enough to drive the transducer themselves, or that you do a sweep and you get the answer. And this is currently what we're working on. I do a lot of
Okay.
work, which was originally helped by the Translation Health Institute of India, which is in Faridabad. And along with the Bill Gates Foundation, we work in the district hospital in Gurgaon, where we create this data, which we know is good, clean data. And with that data, we've already learned that we can identify those patients that have a placenta previa, and those patients that have breech presentation, not with skill. It's a sweep.
Yeah.
It can be done by anybody, and we have a 95 to 98% prediction for these conditions. So in these situations, we started dispensing with perfect skill, but you still need to have the machine left and right. You still need to have the machine switched on. And you just don't have something that is a camera on top and then decides this. No. So it can never do without reasonably skilled individuals, but the lesser skilled will do a better job with AI, and the better skill will, of course, probably not need it.
Because even when you're doing a sweep, you have to teach that person, how to do that sweep. Whether it's below upwards, upwards down, left to right, right to left. Means
Right.
unless all that is taught and standardized, which even an A&M can learn.
Yes. And that is the
And
aim.
then we would have ultrasound right at the periphery where it is needed.
True. And so you see, these machines will serve for stratification. And the important thing, however, is that the person who does it will still need to know which transducer selection. They will have to tell me the preset, even though it's a one button. Transducer, preset, 32 weeks, tuck, and then then he or she does a sweep. So that will still have to remain. We can't dispense with the human element when it comes to healthcare. It will never
So,
replace the human.
so these are, big breakthroughs, and we can see a lot of positives coming around in ultrasound
Yes,
where there is a need, because not everybody can approach Dr. Khurana.
true.
So where there in my Abujmad area, there is a lady who needs an ultrasound. So at least she can be checked to know that, she can go to a higher center now. That at least
So,
referral can be decided upon and we save a life. That is a very major breakthrough. But
yes,
now we come to the negatives. What are the boundaries? Till when and when not?
yes,
One is the cost. One is the
yes.
cost, and more other than the cost. What are the boundaries you feel when we are using AI?
So cost is not really a big deal because just like all other things that are scientific, someone will come up with something cheaper. And we always have our great neighbor China always coming up with an alternative. But we have to realize how much do they come up with something that is reliable. Not everybody in China is incorrect. Not everybody in China is correct. Some of us have had worse experiences, and some of us have had reasonably good experiences. And that is how we work on the Chinese story. And that's where a lot of good AI has come up recently. But the fact is that we really don't worry too much about cost. It will become cheaper within a year or two, just like all technology does. What troubles us is that we are becoming lazier. One of the applications of AI is the actual assessment for syndromes. So, for instance, I have a holoprosencephaly, I have a proboscis, and I have polydactyly, and I'm a young individual who doesn't have that much experience in genetics or obstetrics, and I need a diagnosis. AI will tell me your first diagnosis is trisomy 13, your second diagnosis is deletion 13, your third is duplication 13, and so on. So this is something that is extremely useful, and therefore it lets us realize that a lesser skilled person can do a better job. On the other hand, and that is what is dangerous, is if this lesser skilled person does not realize that this is not the end of the job, that there is much more that can be done, and it is one step in the referral system. We have to sensitize lesser skilled individuals that this is part of a system of referrals where you move from the lowest part of the ladder and move on to higher levels in the ladder so that you can finally achieve good care. And the most intense care is given to those who most need it, and the ones who don't need it can be happily at home in their villages and still have good care. So,
Actually, this is very important, sir, because in our country, the MTP laws are very, very liberal.
true.
So, even at the least sign of something might be wrong,
Yes,
something like a talipus, people are ready to have an abortion.
that is true.
Means unless it's an IVF pregnancy and it's very precious, then it's a different story most of the time. But otherwise, people are ready to have abortion for the silliest of reasons.
Absolutely
Means
true.
one friend told me that, what is fetal medicine? It is fatal medicine. You just try to kill the baby.
Completely so.
That is why I brought up this point that,
Yes.
what fetal medicine is actually doing, what this AI is doing, why we want to see abnormalities,
Yes.
and why we need AI to help out and where we should not trust it completely.
True. Now, for instance, to get a better image of the face, on ultrasound, I have a green line which must be placed in amniotic fluid. And artificial intelligence helps me to recognize that cystic area, the fluid area, and the line comes there. So I can tell the difference between a flat facies and a not flat facies. I then use AI for a differential diagnosis, but I must be sensitized as a human being to make sure that I do not terminate everybody with a flat face because they have every good chance of a reasonable quality of life. So that sensitization has to be done within the profession and within society. Today, society is so ruthless that they allow such terminations to take place, which is sad. The same thing happens when we're trying to look at hydronephrosis. Once I diagnose a hydronephrosis, AI tells me what could be the syndromes and what else I should look for. Beyond that, it tells me also when I need to do a genetic test. But I must have to make sure that my patient understands that as well. And not that every termination has to be done midnight, the day the scan is done. That is incorrect. So we have to sensitize human beings that killing a fetus is not correct. And fetal medicine is not about hunt and kill. It is about giving every fetal an optimal chance. And that is what we're using AI for. And that is important. And that is why the
Thank you,
basics
sir.
of AI is so important. Yeah.
Sorry, I hurt you with that, but that is the thing that keeps coming.
True.
So
Absolutely true.
I just wanted to bring it on this platform.
Of
Now
course.
we've spoken a lot about fetal medicine. What about gynecology? Where do you see AI in gynecology?
Phenomenal. because the first thing that AI does already is to recognize patterns. So in terms of ovarian cancer, which is emerging as something that is so delayed in our part of the world in terms of its diagnosis, most of our patients picked up at stage 3 and many, many at stage 4. We need to identify which ovary that is almost of a normal size or which mass is likely to be malignant versus not likely to be malignant. And therefore, we are now using AI for pattern recognition. We have the ADNEX and the IOTA models, which are automation and
Yes.
mathematical models. But we also have AI, which is as good as a super expert in saying, no, this is all of this. And then it has pattern recognition as the basis for its working. And therefore, I've enhanced early diagnosis of cancer in cases that otherwise would have said, no, go home, you have nothing. Or an
Okay.
endometrioma being mistaken for malignancy and vice versa.
Fibroids, cancer cervix.
Well, let's start with fibroids. Fibroids is very simple. Location. Is it impinging on the cavity? Is it not? Is it truly 4 centimeters or not if it's not impinging on the cavity? And mapping of the fibroids. So mapping of the fibroids is now AI-based, where I sweep and the machine tells me where is the fibroid, which type of fibroid is it? Is it touching the cavity, figure 1, figure 2, figure 5, figure 6, figure 7, and so on. How many fibroids? And then I can play with it and add on fibroids. And I can tell them this is not a fibroid, this looks like an adenomyoma, and then I differentiate. So I have to have my human skill superimposed on that fibroid evaluation by AI.
Okay.
In terms of cervical cancer, with AI, we're not really doing a good job except for risk for cervical cancer. So that seems to be working well. And hopefully we will have AI applications in studying the cytology of the cervix. So the liquid preparations will be actually studied by AI. Those slides that need urgent attention will be put on top of the stack so that the expert can see those, and the rest of the routines can be followed up later because of lack of good people in terms of skill looking at that cytology.
So what is your suggestion about, any of these community-based programs that like you're doing for the PHCs? Or if supposing I want to do a community-based program,
Yes.
what is the gold standard? What is the bottom line?
The bottom line is to give every mother and every fetus an optimal outcome. That has to be our aim. The second is that every country in the world has restricted resources, every country. And we have to make best use and develop a stratification pattern that then improves the efficiency of a referral system. This means that you need to know a system from inside, study it, and then develop a program that is able to give these within the resources available. The other thing is that no government in the world will ever have enough money for health. It has not happened till today. Except for dwindling populations where you have very few people left, like in Sweden. What we need to do is really to make sure that we have a system wherein we have a public-private partnership. And that is where the economy of the country is also headed today. And we use public-private partnership to feed the system to make sure. So those who can afford it will be private. Those who are in public health at the moment or receiving health from government institutions will be handled by public-private partnership. So just like we have highways, just like we have bridges, and just like we have a lot of other things in this country, we can then have the same thing in health as well.
Okay. So when do you think this AI powered machines are going to be affordable so that the government can buy them and actually reach them to the periphery? What is the range of rates that are there? The handheld one, the bigger one, we all know, but the smallest machine which will work with
That is
AI,
true. Yes. Do you
what
know
would be the
that
cost?
one of the companies I work with for technology actually has a machine which the fully loaded AI is actually a medium-end machine and not a high-end machine. The high-end
Okay.
machine does not have that AI as yet. And the one that is currently costing me between 24 and 35 lakhs in private practice, the cost in government are different because it's 5 years fee for maintenance, is the machine that is delivering the AI the best, including teaching me how to do a good scan, completing my
Okay.
list, and making sure I give a full ultrasound report, and making sure that a less skilled individual improves the skills at the same time. And that machine
Okay.
is between 25 and 45, which when translated to any state is a pittance in terms of what is.
Agreed.
Yeah.
Agreed. So it is affordable. And as
Very.
you say, with gradually with time, it will become more affordable.
No, it will become routine.
Yes, it will become routine. So, sir, thank you. This has been a great time spending with you. Means I don't know where I could have had such a long conversation with you. But before we end the session, we are nearing the end. I would like to ask you, what would you advise the youngsters who are stepping out into this field? Whether they are gynecs, whether they are radiologists, means something that nobody wants to be left out on the economic front, right?
True,
Everybody wants, and these days people want it faster. So,
true.
not forgetting their financial dreams,
Yes,
but also to be able to work for the society, what would be your advice and encouragement for them?
yes. The first thing is, please respect yourself, your degree, and the effort that your family has put in, which means that in India today, if a plumber comes to your house and charges you 400 rupees to give an estimate for what needs to be changed in a sewage line, please make sure that you charge a little more than that for your medical consultation. Have some sense of respect for yourself. In a public hospital, the situation is different, and that is their choice. And people who work there work out of their conscience. But in private practice, which is the bulk of practice in India today, the health system is private. We must make sure that we respect ourselves first and realize that we have to have a business sense. The business sense should stop at need and not go on to greed. The rest of it flows automatically. You don't have to run after your destiny. Destiny will come running after you if you follow a basic principle of honesty and self-respect.
Okay. So, how do they plan their future?
They must have some idea on what they need, and they must know what gives them happiness. So your job must inspire you to a certain extent and not just a plain job. The next thing is you should do it out of something that you have thought over and not necessarily impulsively. And you don't have to do it if you don't want to. There are many avenues for doctors in non-medical spaces today. Or you can even become an insurance person. Or you can just go into a completely different field if you're not turned on. But the important thing is that for those of us who prefer to stay in medicine, don't set your goals for your life. Set your goals for today and for a short term. Follow those, revise those, move up, cut them down for a while, change with time, change with the need for family, and move on in that direction. There is no question of saying, I want to be the best. You have to be the best in your own eyes first. So it's really a
Agreed.
question of balancing that out.
So, when I was speaking to you once, you had said that, a stable financial background is a must. So, everybody has
Very
to.
true.
So, so first, become financially stable and then work for your dreams, is what you had said to me.
Yes.
So, if you would like to add something there before we end the session.
Yes. Financial stability is for some of us who are lucky, it's automatic. It's given on a platter and we're born with a silver or a golden spoon. For the rest of us, we must make business calculations. You cannot presume that I will need this much today and not need anything more in the next 10 years from now. That doesn't work. You must, if you're living in a house, please respect the fact that your parents spent on it and put in their blood, sweat, and tears and money into it. and work out a reasonably intelligent economics background for yourself so that you can work it out. But do stop where greed begins and where need ends. The rest will come automatically.
Yeah, but I think, sir, even for your need, you need to respect yourself and be able to hold yourself in your eyes, doing the right thing all the time.
Yes.
Means even your need doesn't actually help you in not doing the right thing.
Or doing the right thing comes first. First of all, there is no question.
That's what.
And you have to be progressive as an individual for skills, for your intellect, and so on. That there is no question. Beyond that, you then need to realize that you have to be a person with a basic knowledge of a lot of other things, or take the help of your friends. What are they called? Investment advisors, wealth managers, and so on, to give you basic advice, or even a newspaper.
Yeah. So AI is the future.
Yes, and AI is the present.
Is the present and the future.
Yes.
So either we accept AI or we are replaced. Is that what you would like to end with?
That is absolutely true. That those of us who accept AI will move on, and the ones who reject PI will be rejected by time.
Thank you, sir. It's been a very enlightening evening. Very, very nice. Thank you so much.
Thank you
Thank you
indeed
for
for having
spending
me.
the evening.
A very, very, very big thank you to you for having me over for this show. Thank you indeed.
Thank you, sir.